We'll get started. So I'm Allison, and I'm here with Elaine, who is co-chairing with me in our lovely panel. And just to make sure you're in the right session, like Gardner said, this is the Innovating SUDEP Prevention, Personalization Tools, and Community Support. So what we're looking at here is really exploring the innovative approaches to reducing the risk of SUDEP through personalized care, clinical tools, and social support. So the presenters are going to discuss how the individualized treatment strategies may help mitigate risk, and the development of future SUDEP risk calculators and tools can help when doing treatment, and the vital roles families, peers, and communities play in prevention. We've heard a lot about that throughout yesterday at Family Day and then throughout today as well. And so together with these talks, we're going to offer a multidimensional view of how we can move forward in better understanding risk and risk reduction for those living with epilepsy like myself and others, and how we can take action and move that needle forward. I know that came up in our breakout and breakout 2, how we're moving that needle forward, and Dr. Nair spoke up about that in our breakout with one of his questions. So you'll hear about that with the presenters, and I'll bring Elaine up to do the introductions.
Hi, my name is Elaine O'Loughlin. I'm Associate Director of Research at Cure Epilepsy. It's an honour to be here today and to help moderate this session. First up on our panel today, we have Tom Nugent, a lived experience speaker. Tom and his family are well seasoned in managing epilepsy, as they have 2 sons who are affected by the condition. Tom is a passionate advocate for epilepsy, using his family's journey to raise awareness and inspire change, driven by the hope that their story can make a meaningful difference to others facing similar struggles. Thank you very much for being here.
Okay, thank you, Elaine, for the intro and the opportunity to share a little bit about our story. And there we go, we'll get started here. So our family does have a very long history with epilepsy. We're going back to the first seizure. First time we've experienced seizures with one of our boys way back in 1998. Now at that time, we knew very little about seizures, we knew very little about epilepsy, and we had absolutely no clue about the journey we were about to go on. And that journey has lasted more than 27 years in managing epilepsy with 2 of our 3 sons. Now, to give you a little bit of sense of this journey, I'm going to focus on one day back in July of 2007. Now, back then, we were already dealing with an epilepsy diagnosis with our youngest son, William. He was 5 years old at the time, and he had been experiencing seizures since he was about 6 months old. And he's having dozens, if not hundreds, of seizures every day. And these were primarily myoclonic seizures. At that time, we were already on about our 5th medication in trying to manage his seizures, and to be perfectly honest, we really weren't having much luck. In addition to the medications, we were also trying the ketogenic diet. And we're having a little bit of trouble at that time with really getting control of his seizures and getting compliance with the diet. In fact, you can see he's the smaller guy in the middle there. At that point, he's pretty small at 5 years old. He had lost about 10, 12 pounds already on the diet. So that was a big concern. So things were a little bit, to say the least, a little bit stressful at the Nugent family. Our middle son, Quinn, who's on the right in that picture, he had actually experienced 2 seizures prior to the day I'm going to talk about. One when he was 1.5 years, and another one when he was about 4 years old. Both of those were chalked up to febrile seizures. Looking back on it, to be honest with you, we didn't really get that connection. We had one son with epilepsy, we had another son who had 2 seizures. We really hadn't drawn a conclusion there was a connection there. That all changed on July 10th, 2007. That evening, about 6 o'clock that evening, I was in the kitchen getting dinner ready for our 3 boys. My wife was out with some of her friends from the neighborhood. And I was in the kitchen, my oldest son, Jack, yells, "Hey, Dad, Quinn's throwing up." So like any parent, I'm kind of annoyed. I got to go clean up puke on our couch. I get Quinn up, and I take him over to the bathroom in case he's got to contribute some more there. And I go into the family room, start cleaning up. About a minute later, I go check on Quinn in the bathroom, and he is standing up in the middle of a grand mal seizure. Now, this is my first experience with grand mal seizure. Our son Will, as I said, had a lot of myoclonics, very quick, very short seizures. And when Quinn had his other 2 seizures, I was not home. So I am in complete freak-out mode as he is seizing. So I take him out of the bathroom, lay him on a floor that has carpeting, and of course, right away I call 911. His seizure does last about 2 more minutes. Paramedics come, take him to a local hospital. And as we're in the hospital, obviously they're going to run some tests. They kept him there. They were deciding, all right, do you want to keep him overnight to do some more tests? As we're sitting there in the ER, about an hour after we got there, he goes into another seizure. This one lasts over 25 minutes. Now, I felt like I was in a movie where all these emergency people come running into the emergency room. They couldn't stop his seizure. They asked me to step outside, so it's a small room, and I'm kind of, peeking in every now and then, just hoping that this seizure would finally end. Every time I peek in, this thing just kept going and going and going. It was a complete feeling of helplessness as I stood outside that emergency room. Finally, after they gave him one of those really heavy anti-seizure medications, the emergency medications, he stopped seizing. Obviously, we stayed overnight that night. Quinn slept. After they gave him this heavy medication, he slept. I did not sleep at all that night. So after staying with him in the hospital, my wife came over to the hospital. She kind of relieved me. I went back home, and luckily my mother-in-law was there. She was helping out with our son William, and I went upstairs to try and see if I can finally get some sleep. Now, before I did that, I had to check in with my company, let them know, hey, I need some time off here. I got a family emergency I'm dealing with. Quinn also was playing baseball at the time. I had to send an email to his coaches saying, hey, I think Quinn's going to need a couple days off here from playing some baseball. Now, after I sent those emails, I just sat there in my room, and really, for lack of a better term, I just broke down. It occurred to me that I have 2 sons with epilepsy. So I'm thinking, how are we going to deal with this? There's just no way. We're really struggling with William. There's no way we can handle 2 boys with epilepsy. What happens if Quinn has another seizure? What are we going to do? How are we going to deal with that? Both my wife and I were working at the time. One of us is going to have to quit our jobs. Maybe both of us are going to have to leave our jobs. How can we keep our boys safe? Now, that was, to be honest with you, that was our low point in our epilepsy journey. I do have a little better news to share, and as a quick update, Quinn, who's now, when you look at that picture, he's the bigger guy now, he's on the left. He did have 4 more seizures, his last being when he was 14, and he's now 27. So we've been able to control his seizures with medication. Thank you. My oldest son, Jack, who's on the right, I haven't talked much about him. He has 2 brothers with epilepsy, and Jack is now a neurologist. Now, he's not a specialist. I wish he was a specialist in epilepsy, but he's in the neurocritical care program at the University of Cincinnati Medical Center. Obviously, his choice of getting into the medical field was very much impacted by growing up with 2 brothers with epilepsy. With William, it's still a very difficult situation. He really fits the LGS syndrome. We've tried over 20 different medications with him. We tried the VNS. We've had the corpus callosotomy surgery. That surgery did help, but we still deal with seizures every day. And obviously, we deal with all those challenges. How to control the seizures, how do we keep him safe at night, how do we keep him safe from falls, and obviously, he's had a lot of physical and mental challenges, mental issues resulting from 23 years of seizure activity. Now, we've come a long way in our epilepsy journey, and we've made some progress, but we still have a ways to go. And I know a lot of you here today, all of you here today, are dedicated to finding cures with different medications, different therapies, different devices, and all the research that you're doing. And all that work has made a difference in our family, and I know in the lives of countless others who are dealing with epilepsy. So I sincerely thank you for that commitment, and I urge you to keep going. Keep pushing, keep fighting for the families like ours. Keep fighting for families who are facing this disease every day. Your efforts bring hope to all of us who depend on the progress you make. Thank you.
Thank you so much, Tom, for sharing that. It's hard living with it day to day, let alone sharing your story of your two boys in a room full of strangers. So we very much appreciate it. And I can hear it myself as a mom to a little girl with drug-resistant epilepsy. It's incredibly difficult, so we appreciate it. Next up, we have Professor Nair, who is a pediatric epileptologist and neurologist at McMaster Children's Hospital. He was the founding medical director of the Comprehensive Pediatric Epilepsy Program. He's also the co-program director of the International Child Neurology Teaching Network, that's a mouthful, of CNA, and his research focuses on the ketogenic diet, DEEs with spike wave activation and sleep, and also, more importantly, what's really focus of our session today is SUDEP communication. So I welcome you. Thank you.
Good afternoon. Thank you for the kind invitation, and thank you, Tom, for that powerful story. I really appreciate that. I attended the PAME for the first time in 2012, and it was all about SUDEP communication, and subsequently I attended several PAME conference, and again, it's great to see people who are interested in mortality in epilepsy and epilepsy in general, and to learn from the families as well as researchers. These are my disclosures relevant to SUDEP that I have funding from these organizations. So let us start with the two actual clinical situations. The first one is a 11-year-old girl with staring spells for the past 6 months. I cannot say past, at that time when presented. EEG showed 3 per second generalized spike and wave discharges and was put on ethosuximide, seizures controlled. Well, the second one is a 17-year-old young man who has recurrent focal seizures for so many years, was tried on several medications without any benefit, and at the time he was on 3 anti-seizure medications. So what would be the predicted outcome that we all think? So contrary to what one would believe, the first girl, I think you have heard such stories, subsequently developed a generalized tonic-clonic seizure, then that confirms, goes with the juvenile absence epilepsy, and had SUDEP. The second young man had a temporal lesion in the MRI, went successful epilepsy surgery and remained seizure-free, and then later off medications. So contrary to what we believe and risk stratifications, when SUDEP happens, it is 100% for that individual and that family. Keeping this in mind, what I'm tasked with is to discuss the clinical aspects of SUDEP prevention. It's a big topic, and we have not reached there yet, but there are some interesting progress. And without knowing the actual mechanism of this particular entity, you cannot really possibly discuss about possible preventive aspects. And this study was published about 13 years back, but still valid as one of the most significant clinical study that looked at the mortality or SUDEP in patients who are admitted for epilepsy monitoring, and these happened at the hospital. So there were 2 groups, people who had SUDEP while in the hospital and people who had really a breakdown in cardiorespiratory function but was resuscitated because the nursing staff intervened. And those deaths happened majority in the night, and who were resuscitated and survived during the daytime. That shows the importance of resuscitation and supervision, and more importantly, more than 2/3 of the patient had, when they looked at the respiratory movement, had an apnea, that is stoppage of your breathing before the heart stopped. So, a brief introduction. I'm sure that we have a basic science researcher, so I'm not planning to encroach into that area. But when you have a terminal seizure, it can spread to the brainstem, and brainstem controls your cardiorespiratory function. And in order to really control the seizure, you have endogenous mechanisms that are activated by liberating, for example, opiates and adenosine. And what does opiates and adenosine do? They suppress the respiratory function further. And when the respiratory function is compromised, look at the right side, and if you have on top of that obstructive sleep apnea, and then you are in the prone position with the face down, and your arousal mechanism in the absence of supervision is further impaired. And if the whole entire cortex is shut down because of the post-seizure generalized EEG suppression, which I will come to later, and associated with any cardiac dysfunction, it creates a vicious cycle, and it plays into the mechanism of SUDEP. So this was published 2 years back. It is highly biased, and it focuses SUDEP following a generalized tonic-clonic seizure. The first one is you have the cortical seizure, and from the brain, just focus on adenosine. The adenosine works on the rostral ventrolateral medullary nucleus, and that controls the respiration. When that is affected, there will be poor ventilation, hypoxia, and when that, so that goes from 4 to 5 apnea, and when apnea happens, what happens? Your carbon dioxide level in the blood will increase, and as a response to that, your Raphe nucleus in the pons, which are serotonergic, get activated. They are sensitive, and they release the 5-hydroxytryptophan serotonin to the periaqueductal gray matter in the midbrain, and that triggers the autoresuscitation. So this is a very scientifically romantic concept that we get to believe that we have some control somewhere along the pathway or at multiple pathways, but this is an example to understand where we can intervene. But again, this is not a unifying hypothesis, because even in the Mortimer study, only 2/3 of patients had a generalized tonic-clonic seizures. But we know that during seizure you can have laryngospasm, so that acts to the obstruction. And in the EEG, so seizure is nothing but net excitation, and the brain tries to control it by inhibition. And when the inhibition exceeds, what you get is generalized suppression in the EEG, and when that is prolonged, that is an independent risk factor for SUDEP. And you can have autonomic dysfunction, associated cardiac dysrhythmias, because you can have genes that shared between cardiac dysfunction as well as epilepsy. So the previous slide is interesting, but it may not explain everything, so you have to take into consideration both sides. So thanks to Dr. Suhasini Sharma, who is sitting there. If you have any questions, please direct it to her. So she told me that when I don't know who she consulted, which biostatistician. So if you take the highest risk, that is about 1 in 100, and if you put in an intervention to reduce the SUDEP risk, and over 6 months, in order to see a 50% reduction in SUDEP, you need like 12,000 patients with SUDEP. That is impossible. So that is the logistical, statistical problem in evaluating the efficacy of an intervention to see whether it can really prevent the SUDEP. So we had to take surrogate markers. The points I am going to take are these in the next 7 minutes. So all of us know that, which is a topic which is very a passion of mine about SUDEP communication. All of us know and agree that SUDEP communication has to happen, but people who are against SUDEP communication always throw in there where, okay, you communicate the risk of SUDEP, so what? Is it going to change anything? So we don't have an evidence to say that it reduces the risk of SUDEP, but I think lack of evidence does not necessarily mean that it is absent, right? You haven't put the appropriate study out there. But this study is from the pediatric age group in India that showed that when the information was conveyed, it resulted in at least 2 positive behaviors from the parents. It includes either administration of the anti-seizure medication in appropriate time, having a seizure protocol, informing the school, having rescue medications, and giving a seizure plan to the school. So there is some positive aspect, which indirectly we can assume that will have result in better seizure control, and better seizure control means reduction in SUDEP potentially. Well, more importantly, this was an adult study, again from All India Institute in New Delhi. What they showed was it increased drug adherence, that is good, but more importantly, it did not increase the stress and anxiety level after receiving the information. So this is very, very important. Now, effective epilepsy seizure management, I think I don't have to lecture on that. Every epilepsy specialist and parents and patients with epilepsy know that this is of utmost importance. And there are a few studies in which if their seizure is mainly in the early morning and the night time, giving a slightly higher dose of the anti-seizure medication at night time may result in a better seizure control. Honestly, I haven't practiced that except in one particular epilepsy condition. Otherwise, I generally keep the level similar. Pre-surgical evaluation is extremely, extremely important. In a patient with a drug-resistant epilepsy, epilepsy offers the best chance of seizure freedom, period. And in Canada, the studies have shown that the bottleneck is not at the level of the family physician, but at the level of the general neurologist, that they don't make the appropriate referral at the appropriate time. So I think there is a role for advocacy there. And patient education about drug compliance, lifestyle changes, sleep deprivation, and a real care plan for seizures. More importantly, now people are attaching more and more significance to sleep quality itself in relation to sleep control as well as SUDEP. So sleep disturbances are extremely common in people with epilepsy, and that needs to be evaluated and addressed. And on top of that, if you have obstructive sleep apnea, if you are obese, and or even otherwise, that needs to be addressed because that contributes to the lack of recovery from hypoxia. Now, people always ask about wearable device. I think that, if you want more information about wearable device, I think I refer you to Danny Did Foundation website. They have, that is the website I ask my parents to refer. But the question is, it is indicated by this consensus that if there is a significant safety concern that, you know what, a young person with not drug compliant, lot of seizures or risk of seizures, and not sharing the bed with someone in the same room, but this wearable device, if activated, the help should arrive in 5 minutes. So if you just say that your son is or a daughter is in university in some other town and you get an alert, I don't think that that will result in any help at the appropriate time. So in selected cases, absolutely. More than that, probably it helps with your peace of mind. But false positives and negatives are very high. Nocturnal supervision, this is controversial because it may not be culturally appropriate and age-wise appropriate in several cases, but the Cochrane review has shown that even the mild evidence for SUDEP prevention is only for nocturnal supervision, and especially if it is combined with an audio device and then you can intervene within a shorter period of time, it may have a role, but it is not proven. But the quality of life issues always persist. But in my experience, in my practice, the parents of a child with a recently diagnosed epilepsy, they sleep with the child for the first 3 to 6 months, whatever suggestions I give, and after 6 months they usually wean off. Then the importance is that probably they can turn the patient from the prone position away so that it will reduce the respiratory compromise. And prone position, we know that there was a huge advocacy and movement to put the baby back on the back. You remember about the SIDS, sudden infant death syndrome, in the past, and then when the babies were put back on their back and avoided prone position, the incidence of SIDS reduced, and there are a lot of similarities between SIDS and SUDEP, and even at the microscopic level, looking at the serotonergic projections within the midbrain, there is similarity. So the question is, would you actively advise them to sleep on the back? Probably that is a good idea, but probably what happens is during the seizure, there is an ictal turning, and they turn to one side, and then there will be face down. So even if you ask them to sleep on the back, it may not really help, but I will encourage you not to at least suggest sleep on the tummy. At least we can avoid that. And there are some anti-asphyxia lattice pillows, and I'm sure that people buy it. There is no study to show it actually reduced SUDEP, but I think that is an interesting concept out there, because you can probably breathe through that, and actually the resistance is actually less. But there was a study about 15 years back that showed that even the rebreathing carbon dioxide concentration, even in conventional pillows and this type of pillows, is not generally that different. Serotonergic drugs, there was one study way back about focal patients with the focal seizures who were on serotonergic drugs had a reduced postictal hypoxemia, but has not been replicated in other studies. There was a randomized control trial planned in 2010. I haven't seen that published. Maybe it was published last week. But again, it makes sense that I have shown you the importance of serotonergic projections. More importantly, patients with epilepsy can have comorbid depression. And psychiatrist asked me, well, since the patient is on anti-seizure medication, can I start depressant medication? I say in uppercase, yes, please go ahead. At least we can advocate for that. Inhibitors of opioid and adenosine receptor, naloxone is an inhibitor of opiate, and in animal studies have shown that when you give naloxone after the seizure, it reduces the post-ictal hypoxemia. That is great, but this study, which was published, I think, after several years recently, that is Epilepsy study, did not find any difference, but they chose patients with a focal seizure. What if they chose patients with the generalized seizures and other types of epilepsies? But they showed that after administration of naloxone post-seizure, it reduces the duration of the post-seizure immobilization. Probably that is helpful. Probably more studies are needed. Adenosine, that is an interesting concept. Adenosine is released in response to seizures, and that can depress your respiratory center. Then why don't we use adenosine antagonist? So coffee is an adenosine antagonist. So don't be under the impression that if you take a lot of coffee that it can do anything good, because coffee is a pro-convulsant as well. So it is a double-edged sword, so you need a better agent for that. So our dream, my colleagues are sitting there, Dr. Robin Whitney and Suhasini Sharma. So we published 2 years back on the SUDEP prevention. So this is our dream, that you put all the data into a machine, and this is AI. They learn about the heart rate variability, the seizure, what happens to the post-seizure cyanosis, EEG, about EEG suppression, all the data, and you get a printout saying that this is a risk of SUDEP. And then that, some of the data can be obtained with the data you get from epilepsy monitoring unit, and of course from home seizure diaries, and on the left side associated with seizure detection devices and individual prediction tools. At the bottom, I see you can have adenosine blockers. The latest drug is istradefylline, which is a drug adult neurologists probably use in Parkinson's disease. disease. So that can be tried, or SSRIs. Yeah, so this I already mentioned. So before I stop, two things. People ask me all the time about diaphragmatic pacing or heart pacing. So if that person with intractable epilepsy has a heart block or any indication for pacing, that we should encourage them to do that early. Diaphragmatic pacing, we have not reached there yet because the primary mechanism, so far as we understand, is post-ictal central apnea. So if you trigger the diaphragm, I am not a pulmonologist, I don't know the logistics of that, there could be a role, but I think in which patient you do that and in how many patients you can do that, I think that is debatable, but three of us believe that one day before we retire, there will be a device that can be like a continuous glucose infusion pump that detects everything at the time of a seizure and release some sort of defiling, naloxone, and SSRI, everything, so that you can reduce the mortality. But things are changing very rapidly in the AI world, so don't be surprised if these things come into the market in the near future. So thank you so much for this opportunity, and I thank my collaborators on this as well.
Thank you, Professor Nair, for your talk and for the additional people that can answer Q&A for pointing them out in the crowd for us. So our next talk from Olivia, she is unable to be here. She got sick and didn't want to bring germs to the conference. So she was able to record her talk very quickly in 3 days for us. So we'll be playing her talk here. So she won't be able to answer any questions, but if you do have questions about her talk, she said to just let me know and I can get those to her. But I'll turn it over to our AV team to play Olivia's video, and you can sit back and enjoy.
Hi, everyone from cold, snowy Cleveland. I wish I could be with you today, but COVID has me homesick, and I apologize for my froggy voice. I'll try to be as clear as possible. Thank you to Partners Against Mortality and Epilepsy for including me in this very important day. Today, I'm going to talk to you about the development of personalized risk calculation tools. I'm a biostatistician and translational scientist at Cleveland Clinic, and much of my collaborating work is in the development of these types of tools. I hope what I review today is helpful to give context to what should be considered when embarking on the creation of these tools. Now, specifically, we'll start by reviewing some vocabulary and concepts so we're all on the same page, and then we'll look at some existing tools in epilepsy. And finally, we'll review the process of how we actually think about developing these tools and think about implementation. So I'll be using the term model to refer to these tools, with the understanding that a statistical model is an equation that incorporates multiple characteristics from a person, right? In this case from a patient, to understand associations or to estimate risk. Now, for those who work in this space, please just consider the term model to include regression models, right, and all their extensions and derivatives, everything with a fancy name that might fall under that machine learning method umbrella. A statistician's bias is that most of that is just regression at its core. Our philosophical orientation. Statistician George Box is widely credited with writing that all models are wrong, but some are useful. As happened with this quote, this is exactly what he wrote. The first is accurate. Remember the model how wrong do they have to be? Not you. So guiding keep it considering. Can principle how unwrong can we be against utility? What does useful mean to us? When we think about these models, we're typically trying to predict an event. Okay, will a specific thing happen, yes or no? Now, in a completely unrealistic, hypothetical scenario where we don't have any information to help us predict, okay, then we theoretically have a 50-50 chance of the event happening, right? It will or it won't. If I sit down to eat chili for lunch, either I will or I won't spill chili on my shirt. 50-50. But we typically don't have zero information. The first information we typically get when studying a phenomenon is a record of how often the event has happened before, right? Epidemiological research. Maybe we know that 8 out of 100 people developed this disease that we're studying in a certain time period. Or maybe I know that 3 of the last 10 times I ate chili for lunch, I did spill on my shirt. Now, based on this past information I can estimate that I have a 30% chance of spilling on myself based on my past information instead of the 50-50 coin toss. But we want to go one step further, right? Not everybody is going to have the same risk of developing a disease or having an event. So we want to see if certain scenarios lead to a higher risk of an outcome than others. Maybe people with a certain risk factor, some demographic factor, an environmental exposure, maybe those people have shown higher rates of developing a disease than other people. Maybe all 3 of the times I spilled chili on my shirt, I was sitting on the couch and not at the table. So now I know that couch sitting is a risk factor for me for chili spills. So the next thing we want to do then, we know a bunch about a lot of different risk factors. Well, how can we combine them? Because people have multiple, combinations of risk factors at different times. People have protective factors, right? So we want to combine these into a single model. We're going to call the risk factor a variable when we're talking about the models. And we can do this with one of 2 approaches. Now, the equation's the same on the back end, same math. But the philosophy and the interpretation are going to be different. Either we build an explanatory model, and what we want to do here is we'd have that one variable, that one risk factor that we're mostly interested in, and we want to see if there's an association between that risk factor and the event. So what we looked at on the last slide, does one group have a higher risk than the other? But in this case, we're going to include other variables, throw other stuff in there, as a way to make sure, as best as we can, that whatever we think is happening between our primary risk factor of interest and the event, that it's actually maybe caused by that primary risk factor and not something else. Okay, so this is the explanatory approach. These are the models that are going to be interpreted with odds ratios, risk ratios on that group level. This group has higher odds or higher risk of the event than another group. Or we can use a predictive modeling approach, and this is what is the foundation of these risk calculators. Okay, so we think of all the risk factors that we can, and then we use some type of fancy variable selection approach to come up with an equation that includes all the variables that do the best job predicting and none of the ones that don't do a great job. And then we use that equation to generate a probability score for a specific person. So it takes into account that a specific person is going to have some risk factors but not others, may have some protective factors but not others, and the unique combination of those then can generate a probability that the event will happen to them based on their specific combination of risk factors. So it's a model that is then used as a calculator. So let's just see what some of these look like in practice. Okay, this is Cleveland Clinic's Risk Calculator Library. Anyone can visit this at riskcalc.org. It includes several calculators that have been developed to predict various post-surgical outcomes for people with epilepsy who are considering having resective surgery. So here's one of them. This one actually is multiple models in one. A lot of the variables overlap, so we kind of just all put it together. But what this is going to do, once this is filled out, it will predict the probability that a person would have problems with language, with memory, or with depression if they have surgery. A user would put in all the specific information about a patient. So here we can see some demographics, some disease history information. We've got information about their preoperative scores on language and memory tests. We run the calculator. So what's returned is probabilities for specific outcomes. Okay, so this imaginary patient would have a 41% probability of experiencing a clinically relevant decline in naming or word finding abilities, and an 11% chance that that decline would actually be severe. We see some different probabilities for decline in different types of memory. These tests measure slightly different aspects of memory, which is why they're different percentages. Or they might experience a 46% chance of meaningful problems with depression. Okay, so these probabilities can be used as part of that shared medical decision-making process when deciding whether to get this surgery or not. Don't have to be used as web calculators. Prior to web calculators, they were best visualized as nomograms, this visual representation of a model. And some people really still like to use these, even with the calculators available. This is the model for post-surgical naming or word finding decline, one of the ones we just looked at on the previous slide. We see 5 horizontal lines, where each one represents one risk factor or one variable in the model: age at seizure onset, site of resection, etc. Now, some of these variables have a stronger effect on the probability of an event than others. Those ones have the longer lines. When you want to use this, you'll find each patient value on the horizontal line, and you'll draw upwards to see how many points correspond to that patient value. So I've done just the first 2 here in red, but of course you would do it for all 5. Then you add up the points, you go to the bottom 2 lines, and you find the risk that corresponds to the total number of points. Okay, so if you want to bypass the computer or just really see how your model is doing, a nomogram. Another way to implement this model is directly with the medical record. This is a model, it's epilepsy this time. It's a medical provider in that the patient is seeing to be given for cognitive problems. This works in the background and it tells patients from the chart and the model to trigger the alert necessary. Okay, decisions with these things in mind. Okay, so who's going to use the tool? Clinicians, patients, family members, and maybe more importantly, what types of resources and access would someone need to run it? For example, if a model only includes demographic and disease history variables, well, that'd be able to be used for a lot more people than one that also might include, say, electrophysiological or imaging information or other information that might be more expensive to obtain or to which all patients might not have access. But oftentimes, the expensive or the difficult to access information, well, that's a lot of the times what helps our models be more precise. So then we're back to that question of deciding whether we want the most precise model possible, the least wrong we can get, even if it can be used for fewer people. Or do we want to accept less precision, accept that we'll be a little more wrong, in favor of more widespread implementation, if that's what utility means to us? Now, we also need to think about what type of interface we want for implementation. Not too much difference between the nomogram and the risk calc. That's user preference. But the automated medical record interface specifically, it's going to be the easiest on the user because it's running passively in the background. But we have to think about what happens with the model when there are missing values, for example, in a patient's medical record. Okay, so what would be the consequences of having the model simply not run for a patient who's missing data? Or maybe we force it to run, but we accept even less precision and more risk of misclassification. Maybe we have an error come up, where the user has to input, just a specific value or two. Just things to think through. And then finally, we should have a framework in place for what actions could be taken depending on the results. Now, for the surgical calculators, that's pretty straightforward, right? You incorporate the model output into the conversations with the patient, and then they decide, do they want to get the surgery or not? But if you're trying to predict different types of mortality in epilepsy, well, what would be the actions that should be taken for a patient who gets a high probability, or even a moderate or a low one? There are also ethical considerations, specifically around consent and how patients may or may not like their data being used in this way, specifically for the embedded chart calculators. So once you have some guiding principles for how you want your model to be used, then it's just nuts and bolts of deciding what exactly your outcome is, how you're measuring that, if that's unclear, putting together a list of all the things you think might predict the outcome developed from prior research and your best clinical judgment, and then you turn over the modeling process to your statistician. And that's where I'll stop today, because no one signed up for a statistics class, unfortunately. But thank you again for the opportunity to share these perspectives with you, and I hope that they will be beneficial when planning this type of work.
Thanks very much for your patience during that technical difficulties. And if you have any questions, please reach out to Alison. It's a great talk by Olivia and a very timely discussion about risk calculators and tools. Last but by no means least is Dr. Sheryl Haut. So Dr. Haut is a professor of neurology and director of adult epilepsy program in Montefiore Einstein up in New York. Her research interest focuses on seizure clustering, seizures and stress, and seizure self-prediction. She's a co-investigator of or co-PI of a large randomized control trial of stress reduction to reduce seizures in the adult population. And she's also been involved in several studies of SUDEP risk factors and prevention. Thanks, Sheryl.
Thank you so much, Elaine, and thank you for inviting me to participate. This is my first PAME conference, and I'm actually ashamed to say that because I've been in practice for decades, but as you heard, I've been interested in many other things, particularly what makes a seizure happen. But some years back, as I'll be talking about, New York State, which is where I practice, introduced legislation that made speaking about SUDEP mandatory for healthcare providers. And that act really sparked my interest because we had to suddenly understand how to do this. Why weren't we doing it already? How should we do it? And so this is the genesis of my being here. And I just have to say that I'm awed by this conference. It's so powerful. Every talk I've heard has been incredible, so it certainly won't be my last. So what is clear? And we've been hearing it all day. Persons with epilepsy and their families and caregivers and friends and extended family want to be educated about seizure-related injuries and SUDEP. At the same time, this group wants to partner with researchers and clinicians towards SUDEP prevention. And in some geographic areas, which I'll talk about, discussing SUDEP is mandated by law. But despite all of this, we're going to see evidence that SUDEP is frequently not discussed with persons with epilepsy and their families and caregivers. And there's no way to obtain support towards SUDEP prevention if we're not talking about it, if the patients and their families are not aware of it. And so there's a lot of literature on this. I've picked a few salient papers that I think bring out different important points. So this was a large cohort from Norway, actually, a few thousand subjects, including patients and caregivers. And you see here that when the first two columns are seizure-related injuries, what they want, what people want, and what they have received. And there's a lot of parity there. So the patients and caregivers want to hear about seizure-related injuries, and they generally are hearing about it. Look at the contrast when you look at the right side of the slide about SUDEP. Similarly, patients and families want to hear about SUDEP. They're not getting it, right? And so why are clinicians comfortable talking about seizure-related injuries, but don't take it to the next step and bring that over to SUDEP? Here's a paper looking at perspectives on SUDEP disclosure, and everybody in this study felt they had a right to be informed about SUDEP. And what I found very important was that, yes, 30% reported that this did generate fear. That's the whole thing. Everyone is concerned about, making patients nervous, making families anxious. But despite that, people still wanted to hear about it. When is SUDEP discussed? This is very interesting. We've been hearing about different countries and their experience, and so this is 5 different European countries. And you see that, in general, SUDEP is discussed, and this is really across the board. The greatest time of SUDEP discussion is when there's a change in risk, or when there's a perceived change in risk on the part of the healthcare practitioner. Not at new onset, except, as you notice, the UK really has better numbers for that. And then certainly when it's requested. But by then, that's too late, as we keep hearing. And then, of course, there's situations where it's never discussed. And we look at, this is a tragic slide, honestly. This is actually there's more than 11 patients, but it's a study of patients who had either SUDEP or near SUDEP, and looking at who received counseling, and those who didn't, did they have potentially modifiable risk factors? We've heard a lot of talks today about what might be potentially modifiable. And so you see, I highlighted a number of the patients who had been seen recently. Their last office visit was recent, and yet they were not counseled about SUDEP. So the mandate is clear. Now, as I've mentioned already, part of the disinclination to discuss this in the clinical setting is this fear that you're going to freak people out. They just, in many cases, they're coming in after their first or second seizure. You don't want to ruin your doctor-patient relationship. You don't want to send them running from your office, never to come back because you've scared them. That is not the case. This was, I think, a very interesting study where there were 2 groups. One group received a educational exercise and an intervention that included pamphlets and videos regarding medication adherence, bathing safety, sleep safety, and other preparation, what to do if the person is having a seizure. And much of this was obviously directed towards the community around the patient, so their family, their caregivers, friends. And after the intervention, every one of those was significantly improved. So that was proof. We don't have outcomes regarding SUDEP, but we have outcomes regarding interventions such as this to improve those modifiable risk factors. What wasn't significantly different? Anxiety and depression. So after hearing about SUDEP and reading all these pamphlets, et cetera, it didn't make anybody more anxious. Potentially it made people less anxious because it's giving you some sort of control over this scary situation. And we've heard this already today. The AES has a position statement on SUDEP counseling, and it's compiled from the AAN and the Child Neurology Foundation, et cetera. And I put this in because I think this is critical. It's a critical message that SUDEP counseling has to be given, and it should, to the extent possible, be individually tailored to be appropriate to the specific epilepsy type, patient preference. So yeah, there may be some patients who don't want to hear about it. You have to respect that. Caregiver availability and engagement and living environment. And again, the majority of patients with epilepsy prefer to be informed. And these were the suggested bullet points to discuss. What is SUDEP? Discuss it. Who's at highest risk? What can be done? And what is the future? Now, now I understand that many of the investigators from these studies are here in the room. In this questionnaire study, and this is just a shocking statistic, the majority of the people with epilepsy and their caregivers had learned about SUDEP from sources other than their physicians. The majority, internet, peers, podcast, community. How can we let this happen? As I'm going to say in a few slides, the role of social media and the internet is critical towards obtaining resources about SUDEP, finding communities that you can feel part of, et cetera. But in no way should that be the place where people are first learning about SUDEP. That is the opposite, really, of what we are all trying to accomplish. And then once the caregivers have learned about this, then they're able to initiate lifestyle management changes. And some examples were, for kids, increased supervision, co-sleeping. We've heard about a number of these modalities already today. And this is interesting. I don't know anything about the company, but I understand that they're trying to develop a medical device to prevent SUDEP, apparently somehow AI-driven, as we've heard about. And they're working hand in hand with the community of epilepsy patients and families and caregivers to develop the tool. So again, when you have engagement between the researchers and the patients and their families, amazing things happen, but it has to be partnership. And the clinicians and the researchers have to be part of the conversation with the patients. So I mentioned this legislation, and I think this is something important and unique. Tim and Alexis Gemga, the family who tragically lost their daughter Natasha to SUDEP, they took it, pretty far. They said, we weren't told about it. We would have made changes. It's a message I've heard multiple times already today. And we want to make it mandatory that doctors discuss SUDEP with their patients with seizures and epilepsy. And this was passed during the 2021-2022 legislative session. And what you see here is that the bill requires healthcare practitioners to provide patients with epilepsy and at an elevated risk for sudden expected death, so SUDEP, with current and evidence-based information about SUDEP risk factors, as well as contact information for nonprofit organizations that provide support. Just to mention the obvious, the Epilepsy Foundation has a ton of resources regarding SUDEP, and you want to be able to direct patients through there. So right now, the Department of Health of New York State, under their SUDEP category, does provide these resources. So this sort of came out without guidance, and that's, I think it's a terrific thing that this exists. There should have been a little bit more guidance to the clinicians. What do we do with it? How do we do it? Do you want to teach us how to do it better? Not everybody knows how to have sensitive conversations. And they did provide this handout. And the handout, goes through what is SUDEP, who's at risk for SUDEP, what are things you might do, as you see there, and many references for support. So in my group, we had this handout, and we were talking about, well, should we hang it up? Should we hang it up in the waiting room, right? That's what you do with handouts, you give them out. And there was pushback. Wow. The first thing people are going to see, they're going to walk in the office, it's going to be staring them at the face, SUDEP, right? Like I said before, this fear that we're going to scare people off, ruin the relationship, et cetera. And what we realized, though, and this is something I had never really thought about, when a patient with new onset seizures comes to the office, that first visit, almost nobody comes by themselves. This is now a new condition. Everybody's scared. The family's there. Friends are there. So they come in with the patient. Later on, the patient will likely start to come themselves. But that first visit, this is the captive audience. This is the time to actually bring this up, talk about it, talk about risk mitigation. So yes, when they come in the office, while they're even in the waiting room, they should see this already. That's going to open the conversation that has to happen when they come inside the exam room. And so we did do that. And I actually have found, because to be honest, even though it's in your mind, it's in my mind to talk about it, sometimes it's a crazy busy clinic, things are happening, and you don't remember to bring it up. The patients bring it up. And they say, I saw out there something about dying in epilepsy. Can you tell me about that? So there it is. So that actually has been, I think, a very powerful tool for us, an important tool. And if you look at the SUDEP awareness group on Facebook, it's an open group, so anybody can look at that. It has a few thousand people, and there are many other groups on Facebook and on other areas of social media. Right after this passed, there was tremendous amount of discussion, including some, very poignant, comments. I wish I had, known this earlier. I wish somebody had told me about this. And then you see that last comment, how do I get this awareness instituted in Arizona? So the message starts to spread. This is the strength of social media, of community, of the internet. This is the way to use it. Have something done on the medical side, have strong support on the patient side, and bring it together. So I think that, to my knowledge, this has not been instituted in any other states. It may be in process, but for right now, I believe New York is the only, but if somebody knows better, please correct me. The only one, yeah. So overall, I say it again, we see it. Persons with epilepsy and their families and their caregivers and their friends want to be informed and educated about SUDEP. Discussing it improves outcomes, does not worsen anxiety and depression, and by discussing it and providing resources, the healthcare professionals are able to enable the caregivers to make lifestyle changes to reduce risk. We can't let it happen that our patients and their families are learning about this from the internet. Again, we want to use the internet to reinforce, support, help, but not be the first step towards educating. And I'm very excited to see, just from one day here, that there are opportunities where patients with epilepsy and caregivers are joining together in research towards SUDEP prevention, and I think the future is going to be exciting with that. Thank you.
Now we have time for Q&A, and I want to thank all of our panelists first before we get started on that. I don't know if Mary and Tom, or maybe I can tag you guys to run the mics for us. Thank you, Danny. Team Danny did. So if you have questions, you can put your hand up or write them on a card, and then Tom and Mary will come around. And then we have plenty of time for a Q&A, and then we'll have a break shortly after. And I see
my question's for the last speaker. Is there any regulatory parts to that law in New York? So how do they know if the provider has provided that education? Is there consequence if they don't? What is the regulation on it?
It's the fantastic question, and it's an obvious question that I do not have an answer to. We all wondered, well, what, are we going to go to jail? Are we going to get, what happens, and how do they even know? And again, that's part of the lack of information. This happened. This is so important, but it hasn't yet been operationalized into, something that can be tracked. I hate to say it. You don't want to find out that you didn't do it because of a bad outcome, and then the family says, well, we're in New York and you never told us. So I would say, even though there isn't a method to track it, and it's unclear what would happen if it turns out that you didn't, it's still such a powerful incentive to remind everybody to do it that I think in the big picture, it's a very good thing, but certainly it's not perfect.
Okay, thank you all. You all were great information. Again, I am one suffered with epilepsy. And question is, as far as SUDEP and all of the great information that I've learned here about SUDEP because I wasn't told about it, are there any resources for someone like me who now might be a little bit more paranoid because I've learned so much more about it? I've had grand mal in my sleep where my tongue is torn up and my own permanent tattoo on my arm, or I bit my arm. But what about that? Is there a resource for that where you can reach out, or should you just, continue to stay strong? Or I don't know. Allison, help me out here. Because the paranoia, I'm like, I'm scared. I don't sleep well already at night. So I'm like, what if I go lay down and take a nap? What am I,
Maybe turn to Tom on that, because Tom talked about devices and things like that that Danny Did Foundation helps educate the community on. So Tom, if you want to speak to that.
Devices are a big thing. We've been using, back when this first started, we started using baby monitors. Now we've increased that and used some more dedicated monitors for, epilepsy and movement monitors, and we're exploring kind of the next phase, which might be wearables. But I also would say, I know for the first, 8-9 years we were dealing with this, we kind of felt we were out there. You're kind of out there on your own dealing with this, and you're really you're very myopic in your viewpoint. I started getting involved with more, not just fundraising for groups like the Danny Did Foundation, but getting involved with more, I attend a lot of webinars. I do a lot of research on my own. That gets me more involved in the epilepsy community. And first off, it makes you feel better, more confident that you're doing your research and you feel part of this larger group and you're not just kind of out there on your own dealing with this. So, yeah, I'd say like what you're doing right now. You're attending this conference. You're learning. You're learning about maybe some other devices or other things that could help you. And I would just encourage you, just continue doing that. Get involved with what you can. Now, don't overload yourself, but I just know the more of these things that I get involved with, the better it is, and better I feel about taking care of both my boys.
Yeah, since the brain surgery and the implant and all, what really has helped me, and I appreciate you saying that, is my involvement, advocating, going to D.C. for the Epilepsy Foundation, and being a member at the Morehouse School of Medicine with an Emory for Epilepsy Community Advisory Board, and that type of stuff, like you said, is a huge help to get out and help and advocate for someone else, and so it won't be like a selfish movement. And I really appreciate that. And the last question is like the seizure watch and the piece of scientific information you said. Would someone like me be eligible for that because I have a DBS stimulator? Would I be eligible for that type of scientific neuroscience technology, or that wouldn't be available? Would I have to go through my doctor or reach out to you guys, or how would I know about that?
I think Professor Nair, she was talking about in your last slide, looking to the future about, hopefully that.
Okay. So wearable devices. I think Tom would be the best person to answer that, because what sort of funding is needed or available, and what are the prerequisites for that funding. I think Tom would be the best person to answer that. But before that, I think just to follow up on your first question, the two words that I remember are, one you said, nobody told me, and the second is, I am paranoid. So if nobody has told you, when you hear about new things, it is natural that you become paranoid. So the question is, why nobody told you? I think if you have that healthcare provider, I think it is better to have that conversation with him or her to get a closure. So the closure is very important when you feel that you should have been provided with something, but you are not. I think that is the first step towards healing, and then becoming paranoid. I think the support system is in we work in Canada, which is not the 51st state. It is a separate country where it's a separate system we have. If they have any questions, we have wonderful social workers and highly trained nurses in our clinic. So if they have any question, there is a phone line they can contact, and we have very dedicated epilepsy community, epilepsy agencies who are really trained and passionate about mortality in epilepsy. For that, probably you may have to migrate down north, up north. That is my answer for the first one. But second one, I look forward to Tom's answer.
And Tom does have a microphone, so.
Yeah, no, I would encourage you to look at our website. We have a lot of different device options, non-invasive options that we talk about. And our primary, focus is to help people get access to those. So we'd be happy to talk through what might be a fit for you, what you're looking to gain from a device. There's different outcomes that people might want. And we talk through the options. We want to make sure there's a good alignment, a good fit. And then if there's a financial need, we help with that too. So we can talk offline about what might work for you. Yeah.
Oh, I see a hand in the...
Hi. Oh, sorry. Hi. I really appreciated everyone's presentation, and my question's for the last speaker. My brother passed away from sudden unexpected death in epilepsy in 2017. He had every single risk factor, and we were never educated about the ways to reduce the risk or what SUDEP was. This past year, we were able to pass Dillon's Law in Oklahoma, and when we had first introduced it, I was told from some that the shall language was, sort of tricky, and so we passed shall, putting it on the Department of Health. I'm wondering, after hearing your presentation, would you encourage us to go back to the Oklahoma legislator and put shall on the doctors as well if we gave them a civil exemption from liability? Because we're not interested in suing doctors. We just want to also have shall not only on the Department of Health, but the physicians. And I'm just curious your perspective on that, if they would be interested in that kind of legislation.
Well, I don't have that much political experience, but I think when you have a precedent in one state, it should pave the way elsewhere. And I think that's what you said is such an important part of this. It's not about liability, and it's really about increasing education and just something like this. When a law is passed, it makes every healthcare practitioner need to hear and think about it and say, well, am I doing this? And again, sometimes the initial response may be, oh, they can't tell me what to do. I talk to my patients the way I want. But that's okay. It that quickly passes, and then you realize, wow, but I haven't been doing that, and I need to. So I would strongly encourage you to try and pursue that in Oklahoma and others elsewhere.
So I would raise a concern about approaching this issue through law, and this is based in part on sort of the findings that our work group had around driving regulations, right? I think we were surprised and taken aback by the number and severity of unintended negative consequences of well-intentioned laws in the domain of driving safety and epilepsy. And I am concerned that there may be unintended consequences if this pattern of legislating best practices around SUDEP education progresses and continues. So, a couple of concerns that particularly strike me. One is, you as an expert practicing in the state in an epilepsy center where this law has been passed don't know the legal consequences of the law, and you're an epilepsy specialist, right? There are general neurologists, there are emergency medicine physicians who have much less expertise than yourself, who are also responsible for caring for patients with epilepsy. So you can imagine how much less informed they're going to be. Another concern about the law, and so you can imagine that those clinicians may have real concerns about interacting with patients with epilepsy, about counseling patients with epilepsy, being unsure about what repercussions might result from those interactions as a result of this law. Another concern about laws is that they tend to be very hard to change and modify as new evidence develops. We were just talking in a recent session about how the definition of SUDEP is about to change. And the law is not going to change when that new definition is produced. And legislatures have been notoriously poor at modifying legislation around medical practice as new evidence becomes available. So a few concerns that I have: I completely agree that education around SUDEP is essential. There should be guidelines for physicians. There should be education for physicians. I am concerned that laws may have unintended consequences that may have negative impact on patients in this area.
Yeah, I'll just say I completely agree. This would not be the optimal way to go. Earlier in the breakout session, I think it was Dr. Sharma, I'm not completely sure, brought up that possibly you do this through CMS and make it a billing thing, right? You've got different directions, but if none of those would need to happen if truly the neurologic community and the pediatric neurologic community made sure that everybody learned about this and knew how important it was to discuss. That's aspirational. Maybe that would be the way. But I think the fact that we don't know about any consequences for not doing it is because likely there aren't. Everyone was asking, well, what happens? How do they know? And there never were any answers because, again, I think it was more as something to make sure that every physician downloaded those forms. Even if everybody put up those handouts, that would be in advance, right? Because that opens the conversation and the patients see it. So it's imperfect. I hear you, and especially the part about the fact that you can't update laws when new information comes out. So I think there's different paths to get to where we want to go. This is the path New York has taken a few years ago, and I do think it has very much expanded how often SUDEP is discussed. But you're very valid concerns.
I have a question for my own knowledge sake. So this legislation, does it say that any healthcare provider who makes a diagnosis of epilepsy should discuss SUDEP with that patient or the caregiver, or is it only for the neurologist?
Oh,
Yeah, Laura has it. Go ahead. Laura's the Chief Government Advocacy Officer at Epilepsy Foundation, just as background.
Yeah, so the New York law, the specific language is any healthcare practitioner who's treating a patient diagnosed with epilepsy and at elevated risk for SUDEP. And to the previous question about are there any repercussions for the doctors, it says a healthcare practitioner found to be in violation shall be issued a warning and shall suffer no further civil penalty or discipline on any first offense, provided such violation was not committed willfully and knowingly. So it's pretty thoughtfully done. I think one other thing I'd add just to this discussion, and we're definitely in support of more conversations, doctors infusing it as much as possible. The New York law, I think one aspect of it that we haven't said yet was, my recollection, it was done in response to like one specific tragedy. I mean, obviously advocacy at large, but there was one horrific car accident, where people weren't very unfortunately killed that kind of led to the momentum for this, which should never happen. But it's tough to legislate, and it brings in the driving stuff too. But it's tough to legislate, based on one situation. So,
a quick question for Dr. Ramachandran Nair. I'm concerned about the SUDEP and the epilepsy monitoring unit that you were mentioning. Are there any specific factors? Is it like just the intractability of the seizures, or does it have something to do with how quickly we stop or taper medications? Is there any best practices to avoid that?
Well, I think let us go back to that study. Study was done in Europe, and New Zealand, Australia, and Israel at that time. And these were patients electively admitted to the epilepsy monitoring unit, majority for epilepsy surgery workup. So it is a highly biased population. And what they found was the people who died, majority of them died during the night, and none of them had an intervention from the nursing staff before 5 minutes. And some were never even detected, and for many hours. Whereas the Nair SUDEP, which is defined as everything else, the early vegetative, neurovegetative breakdown of the heart rate and the breathing, that happened, but they survived for at least 1 hour after the event, and when they looked at that, they were all attended by the nursing staff, and the usual time period was 1 to 3 minutes. So interesting things happen even at prestigious institutions at night. And at daytime, people are more vigilant, and that shows that supervision and perioperative care can probably reduce the risk of SUDEP. So in translation to clinical practice, the best method is if you are tapering the medication, as often we do in epilepsy monitoring units, you need to have an institutional guideline how to monitor each and every seizure and in what time period you need to intervene. So without that, I think it is ideally we should not have drug tapering in epilepsy monitoring unit. I think that is the practical application of that. But just to follow up on that legislation, I think, sir, your concern is very valid that suppose this is a family physician, the patient goes there and has got 2 seizures, because the discussion about SUDEP is extremely hard even on a neurologist and an epileptologist. It is not as easy as one might think. So if people are reluctant and they are not very comfortable with their own communication skill about bad news, probably, I'm not accusing anyone, or probably that might happen, they can say that 2 seizures, not diagnosing with epilepsy, refer to neurologist for further workup. Is it negatively affecting that patient that a timely diagnosis of epilepsy is not made and appropriate medication was not given because of the legislation? I'm just being the devil's advocate here.
We have time for one more question. Okay, I think Mary has it.
Thank you, everyone. I just want to go back to the previous question, and I can hear the concern of the medical professionals and the legal consequences they can get when there is a mandate and if they don't follow the mandate. But as a parent, that was the only way. I'm new to this, but I feel like we had to twist some arms basically to have that conversation, because my daughter, as I said, passed just 7 months ago, and I remember during her first visit she had a question for her neurologist asking what are my chances of dying from this, and the neurologist never mentioned SUDEP. She talked about drowning, water safety, driving, all that, but SUDEP was never actually mentioned. So my question is, for example, I hear from a very dedicated neurologists and specialists and researchers in this room, but how can we reach the others? Because as myself, from my experience, I'm a teacher. To keep my license, I'm required to be up to date. I'm required to do training every year. I'm required to earn points to keep that license. So you guys are dealing with lives. And I'm not trying to be rude about this, but I'm just saying, how can we reach those people out there without actually having to go through this fight of, we're not working against you, we want to work with you, and we just want to know how we can work with you to reach also people that are not in this room. One of them is my daughter's neurologist. Thank you.
You want me to take up on that question?
I was going to say, I can
please, go
answer
ahead.
real quick and pass it to others. So there are many groups, the advocacy groups that partner with like American Academy of Neurology, like Epilepsy Foundation works with American Academy of School Nurses doing seizure first aid trainings, and within Epilepsy Foundation's seizure first aid training, they discuss SUDEP and educate on SUDEP. There are seizure safe school laws in the country. Laura, correct me, I think 29 states? Okay, ish. And so they're all required to take the seizure first aid training, and so they're learning about SUDEP because it's in the first aid training. Also, PAME is going to be creating a SUDEP CME module with AES. We just got approval of our proposal this year, which we're excited about, so we're starting that project in January. So on the AES learning module portal, there is not currently a SUDEP-only training module. You would think that, but if you Google SUDEP, different trainings come up because SUDEP is mentioned in different trainings, but there's not one just on SUDEP. So we will be designing one. It's we get CME credit. We'll be able to share that. So, you know, as I've said, you know, we work with those different groups that aren't here. Dr. Jeff Buchalter, who we saw earlier today, he's given talks at American Association of Physician Assistant conferences about SUDEP. So it's really, to your point, Safa, reaching those groups that aren't here. So the different, you know, advocacy organizations and groups have made, you know, really strong partnerships with those groups to get that education out and have those folks here. American Association of Neuroscience Nurses, like all these acronyms are coming in my head. We were at American Public Health Association this year doing a presentation and all of that. So we are working to, you know, talk to those individuals that are outside of here, because we know, you know, it took me 14 years to get to an epileptologist, so we know not everyone is being seen by a specialist, so we have to get to those, you know, PCPs, neurologists, and all of those to educate them on, you know, SUDEP and risk reduction. I'm happy to pass it along to anyone
I
else.
think you answered it very well.
Thank you.
Thank you.
So, well, with that, we have a brief break, I believe. Thank you, guys. Oh, sorry. Yeah, so we have a brief 15-minute break, and then we'll come back for our last plenary at 3 o'clock. So thank you to our panel.